Hi, welcome to our May seminar as part of the Prevention Research Center for Healthy Neighborhoods seminar series. Today is co-sponsored by the Community and Collaboration Core of the Clinical and Translational Science Collaborative at Case Western Reserve University. In today's seminar, Dr. Dana Prince and Dr. Scott Moore will provide an overview of their CTSC Community and Collaboration pilot study and address the range of opportunities and challenges that they identified in the process. They will discuss the benefits of engaging the sexual and gender minority community in all aspects of the research process and provide a few of their early insights from their data. Before we get started, just a few logistics and housekeeping for today's seminar. We recognize that in this format, you can't see who all is on the call. If you could please use the chat feature to write down your name and organization to let others know who is here and joining the presentation, we'd appreciate that. For questions, we ask that you please use the Q&A feature. Also, there is a raise your hand feature, which can be used during the question and answer periods if you would like to request your microphone be unmuted. We also ask to learn more about our center as well as future seminars, so please connect with us through our website and our social media. And I'd like to welcome our speakers to today's seminar. Dr. Scott Moore is co-primary investigator for the Rainbow Connection study. Dr. Moore is an assistant professor at the Francis Payne Bolton School of Nursing at Case Western Reserve University. He earned his Master of Science in Nursing and doctorate from Clemson University, where he had predoctoral training support as a Patricia G. Archbold predoctoral scholar for the National Hartford Center for Gerontological Nursing Excellence from 2014 to 2016, and the Oliver Kent and Betty C. Cecil Fellowship in Geriatrics and Genetics. He then completed a National Institute of Nursing Research-funded T32 postdoctoral fellowship at the Francis Payne Bolton School of Nursing. Dr. Moore's program of research examines the influence of the complex dynamics among biological, psychosocial, and systems factors, including sex, gender, and minority identity-based differences on quality of life and health outcomes among adults and marginalized populations. He is an expert in quantitative and mixed methods, behavioral economics, and has extensive clinical and interventional experience working with vulnerable populations, including sexual and gender minorities. Prior to joining the faculty at the Jack Joseph and Morton Mandel School of Applied Social Sciences at Case Western Reserve University, Dr. Prince completed her NIDA-funded T32 postdoctoral fellowship at the Yale School of Medicine. In 2016, Dr. Prince has developed a robust program of health disparities research that focuses on the transition to adulthood for vulnerable and marginalized youth, most notably substance use, incarceration, and homelessness among adolescents and young adults transitioning from foster care. Sexual and gender minority youth involved in child welfare face additional risks. SGM is the NIH designated definition for individuals who are a sexual minority, such as lesbian, gay, bisexual, and or have a minority gender identity or expression, example, transgender, gender nonconforming. Dr. Prince's federally funded research aims to understand the mental health and service needs of SGM child welfare involved youth and to develop and test multi-level interventions to promote optimal health and well-being. Welcome, Dr. Moore and Dr. Prince.
All right, I am gonna get started. Sorry, lots of clicking. Does that work? All right. Hi, and thank you so much for coming today. And I am really excited to be here with my co-PI Dana to talk about this work. Just a few things that I want to make sure that we point out to begin with. First, the results that you're going to see today are early results. They're not completely processed, nor are they we're still sort of discovering themes and other aspects related to the outcomes of our study as we're going. So we would appreciate it if nobody publish them or reference them without talking to us first, so that we can make sure that they are given the appropriate clarity within the context of the study that we did. So thanks for that. And then next, I want to start by acknowledging the fact that we're on borrowed land, and specifically understanding that this land is the traditional homeland of the Lenape, the Shawnee, the Wyandot, Miami, and the Ottawa, Potawatomi, and Great Lakes tribes. We don't have any disclosures to make at this time related to the content in this presentation. We have to be upfront and start by thanking the people that made this possible. And obviously, the community and collaboration pilots are supported by the marvelous people in the CTSC. And we obviously wouldn't be able to do some of the work that we've been doing without acknowledging our community partners, who I think are amazing. The LGBT Center of Greater Cleveland, Connect, as well as A Place for Me with the YWCA. We also want to acknowledge that we are really grateful for the voices that the participants have provided to this work. I think one thing that you'll see through our discussions today is that there's still a lot of work to be done. And the fact that we started these conversations has created a lot of depth and, I think, really important opportunities for us to explore the things that we don't know, or the assumptions that we're sort of flying blind by continuing to believe. And also, we have to thank the people that have supported us along the way, because as early career investigators, we wouldn't have this opportunity without family, friends, and mentors and colleagues who have been there through the good and the bad and all the other things. So now that all of that is done, I want to also introduce you to the people whose faces you may not be able to see on Zoom today. Dr. Laura Mintz is our co-investigator. She's a physician at the Metro Health Pride Clinic. Braveheart Galani is a doctoral student in the Mandel School of Applied Social Science, and he has been an integral part to as a graduate assistant. Jackie Brose is an undergraduate nursing student at the Francis Payne Bolton School of Nursing. Megan Ray Novak is a doctoral candidate at the Mandel School of Applied Social Sciences, and Enrique Francis is a Master in Nursing candidate at FPB as well. So let's talk a little bit about health disparities and healthcare transitions among sexual and gender minorities. So the first thing that we have to realize is that there's a disproportionately high risk for mental and physical health disorders among SGM individuals when compared to non-SGM individuals. And these disorders do not just end in adulthood after you come out, but they persist across the lifespan. There's not a single source predictor for these differences, and they often have complex etiologies, including biological, behavioral, and social factors. And I think that through the narratives that we share today and some of the initial findings, that you'll see that the complexities also are very pervasive in the systems themselves. SGM also have higher representation in child welfare and juvenile justice systems. And then it's really also important for us to realize that there are some really high-risk milestones that SGM may be facing across the lifespan, both from pediatrics to adult healthcare, as well as transitioning into long-term care facilities. And I think that we'll give some voice to that a little later on.
Okay, thanks, Scott. We also really wanted to talk a bit about our researcher positionalities. And it's really important to us as a study team to acknowledge the fact that all the core investigative team members, myself and Scott and Mintz and Galani, are queer and trans identified. So we have unique insider-outsider positions as being a part of this community that experiences health disparities. We have our own stories of being inside of health and mental health care services as queer and trans people. And we are also in a position of privilege as being researchers and collaborating with our community partners. So there's a lot of ethical considerations when we do this work and take into account how our own roles and our own lived experiences are contributing to the study across the whole process. So a few things, I'm going to jump down to community embeddedness and then come back up to the role of emotion, because that's something that's really come out in this process. This study did not start when the call for applications for the grant mechanism came out. And I think that's really the most important thing that we can say is the initiation of these relationships is longstanding. Both Scott and I have personal and professional relationships with the LGBT Center, who is our core community anchor partner in this. I have had other funded research studies where the center has been a core anchor partner. And we both also have other relationships with that space and with people in that space. And so the idea of relationship building is something that we talk a lot about in community embedded work. But there's a particular kind of asset building that we have as this insider-outsider perspective, that we have a long-term stake in building these relationships and ensuring that collaboration and not transaction is happening. This is especially heightened now. We know that there's an increase in recognition of the dramatic physical and mental health disparities that our population, that our communities face. And we know that NIH, since 2016, and designating us as an actual health disparities population, which came after a long fight and a lot of political insider kinds of things. But since that occurred, there's been more and more funding mechanisms that have been targeting our communities. And we think that's really exciting. That's an important move to actually allocate resources to investigate the cause and the antecedents and also the intervention points to change the landscape of health and mental health for sexual and gender minorities. But it also means that places like the LGBT Center are now being sought after as research partners in high demand from folks within the research community who may or may not have established relationships. And there's some tensions there, and there's some experiences that, not unlike many other minoritized communities, the idea of helicopter research and folks coming in to partner, but actually it's a very transactional kind of an approach of getting data or getting information and then leaving. So that is not our ethos as community embedded and grounded researchers, as members of this community in which we work and serve and live. And we have a long-term commitment to changing the landscape of health equity and advancing social justice for our communities. So that is the ground upon which we are standing. Now, trust happens over time, and we continue to build trust through the ways in which we engage and show up as researchers and as people with our partners and in our communities. And it's something that's earned. So another point that I wanted to highlight is this work has been incredibly impactful, not only for folks who have participated and shared their stories, but also for those of us on the study team because of our own lived experiences and the kind of stake that we have in making these types of changes. So I'm going to stop there, but happy to talk more about some of those complexities in the discussion and answer section.
Thanks, Dana. So briefly, I want to just let you see our aims, and we're going to go over these more specifically later on. But what I want you to understand is that this is a two-phase sort of parallel and also chronological approach where there's things that are happening in both phases that will end up coming together in the culminating publications. And so we'll be talking about the two different methodologies that we used, some of the unique nature of those things, as well as some of the things that that we're anticipating being able to talk about in publications. So aim one of the study is the aim that guides phase one of the study, which our goal was to apply a modified Delphi approach to assess the fit of the transitional care model for the needs of SGM populations across the lifespan. And so, you know, just a little bit of context, the pandemic had started the day, I think work from home started the day that these applications were due. We had already had most of our, we had our application done, but the process of planning for pandemic specific protocols was also part of the aspect that we were trying to address as well, so that we could be safe, so that our participants could be safe. And it actually, I think, created an opportunity to really leverage the pandemic as a way to cause us to innovate. And I think that it's going to make us happier in the end. I don't want another pandemic, and I don't want to, you know, give it praise by any means, but I do think that it has created some really neat opportunities here. The first is talking about the modified Delphi process, and Delphi processes have been used in a wide variety of settings and roles. They can be done in different ways. They can be done in person. They can also be done using online surveys. So that wasn't really unique, but we wanted to leverage this approach because we wanted to break down the hierarchies that often exist between providers and patients. And this is where, if you're a patient and you're not feeling comfortable talking to your provider about the way that you're feeling in their office or other things, that you could actually talk about these things as we go through the process. We also were really hopeful that it would help us to identify both the nuance and the contrast in the areas that sort of get sort of washed over or become grayed out. And I think I'm going to show you that in a couple of slides here. But also, the iterative meaning making, I think, is super important, and not sacrificing those specifics, the voice of the people. Like, I think that I can't agree with Dana more than when she talked about the emotion of us as researchers that has come out in this. And it's the fact that we've seen people writing their own stories and saying the things that we've known deep inside of us, and finally somebody saying it out loud. And I think that that's super important, because we're not losing that as we're moving to consensus. We're actually building a swell of information, too much for us to put into an hour-long presentation, but it's really exciting. And I think, yeah. So let's talk about the first thing. If there's ever anything that I should tell you, and you probably already knew this, but words matter. Even as SGM identifying researchers and providers, we went into this with this beautiful definition of what healthcare transitions are. That they're defined as movements between different specialties, levels of care, and we gave some really evidence-based examples there that are places where we know that transitions have occurred. But unfortunately, the word transitions is potentially confusing when we talk about it in the context of SGM health, because it can be conflated with the idea of gender-affirming care. And so briefly, gender-affirming care is the care that is provided to individuals who identify as transgender or as non-cis. And in that process of healthcare, it is providing care that is affirming to their affirmed gender identity. And so that can include a wide variety of different resources and treatments or types of care. So I don't really want to get too deep there, but it's a very specific flavor of healthcare, if you will. These are the terms that are just some of the terms that were recommended for us to change this to. And notice that the word transition doesn't exist in any of them. And in the process of trying to understand how to better describe this, the description itself wasn't actually the problem. It truly was just the terminology that we used. So that's the first small, tiny, yet very valuable lesson that has come out of this. I want to talk about the transitional care model because it was our original concept and sort of a seed model that we used to start the Delphi process. And it was developed by Mary Naylor at Penn School of Nursing, and it has been studied in numerous RCTs and other funded studies from the NIH and foundations. And it's been applied across the continuum of life. And the thing that I think is also really important is to know that it has now been accepted in healthcare practice. It is a billable service, and that's important. It's also recognized as best practice in taking care of populations who are moving from acute care stays to other to long-term facilities or some other places. It doesn't mean that we can't change that definition to include across the lifespan and addressing other types of transitions. The other thing is that in 2015, Dr. Naylor's team did a systematic review of the adaptations that had been published of the transitional care model and identified 342 unique adaptations, but none of those specifically address sex and gender minority individuals. And so that was our hope, is that we would be able to use these two collaborative approaches to create an opportunity for a new model. So Naylor has identified these key elements, and I don't want to get into the big definitions. I mean, we could spend a lot of time talking about definitions, and I will show you some of the discussion surrounding the definitions in a little bit, but specifically, these key elements are what Naylor, through the research, identified as being essential for creating a transitional care model. And so in the Delphi process, the first iteration was for us to ask our respondents in the panel to identify their perspectives on the importance of each of these key elements, the relationships among these key elements, as well as how they might change the definitions, and also what some of the forgotten or overlooked factors might be. And so today I'm going to show you first a mock-up of where the model stands at this point in time. And this is a lot, so I'm going to break it down briefly, but I guess the key parts here are, you see that it's not necessarily a linear relationship here. That just because you get one doesn't mean you get to move to the other, get to move to the next. It's not how this works. But I think there's really important parts up here. These three things, without a doubt, have been clearly identified as super important in establishing what our panel believes to be a successful transition of care. Staffing itself, screening to identify those who are at increased risk, engaging the individuals and caregivers, and then also how we assess and manage the symptoms and risks. And I think that it's key that we have a starting point now, right? So we've identified this as being the place where most things are related to the others. But as you can see here, staffing itself, so each line represents a relationship that was endorsed by over 50% of the panel that we have. And so this is 21 individuals that span practices and patients, and the age range of 18, I think, to 70 something. We didn't ask specific ages, just so that it would be less identifiable, if that makes sense. And so each arrow identifies a relationship that was endorsed by them. as well as the direction of that relationship, meaning that staffing has to be completed before you get, or identifying a staff that is capable of doing this work has to be done prior to being able to do the work itself. So again, people matter. Additionally, in order to actively assess and treat, maintain, and collaborate, you have to have a really competent screening and engagement and assessment and management system in place. And then as you see, the relationships themselves later on are not quite everything relates to everything else. So there are certain other relationships, and I think as we continue this work, that we'll be able to sort of identify some differences here that are really important, especially with this community. So I want to talk a little bit about what transitional care model key elements mean for the sex and gender minority individuals. So when we talked about screening, one of the things that was said is, does someone have to be at high risk? So why do we have to make it a high risk? Why is the bar so high that someone has to be at that level to get transitional care? And I think that this is a thing that I also want to point out that is super important. The idea of being closeted and recloseting and re-coming out. This is not the first time that this has come up, and this will not be the last time that we will see this either. The other is about maintaining relationships. And I think that I want to be clear that some of the things that we're going to be sharing may be sensitive for some people. I will read out certain parts of them, but I won't read out all of them. We did not, I mean, we don't believe that there's anything that's overly specific that may upset anybody, but we also want to be cognizant that some people may have different experiences with their healthcare or the people who they have relationships with. So I think the key part here is that you see that family itself may be a problem that has to be addressed. And then similarly, we can't allow healthcare to make assumptions about relationships among individuals and their caregivers, nor can we define what their caregiver identity has to be. And then I think that this is probably one of the most important things and has sort of led to a side paper that Dr. Mintz is working on now is providers may not necessarily be the ones that are best at identifying the risk factors. And I think that there's been a lot of paternalism in healthcare, and that aspect of, oh, you just sit back and let us do what we need to do, has been problematic outside of the SGM community, but it's also very problematic within the SGM community itself, because there may be over medicalizing of identities and under recognizing of other risk factors. Because I think the key part here is they often believe SGM individuals to be at risk for things they're not. So then when we asked them about some of the uncovered aspects, we also had some very important statements. And I guess the first is that there has to be more focus on what the patient desires, but also what access to basic needs they have. Notice that this model does make some assumptions, right? It assumes that they have consistent housing, food, and support and transportation. They also talk about health literacy and insurance coordination and coverage. But this is also real. This model doesn't allow for us to understand microaggressions and the experiences of individuals entering into new systems. Again, we see the complexities of family. This is not a new theme in SGM research or SGM healthcare. But I think that hearing a statement from someone who's involved in the processes on a daily basis or has experience with these processes is really important. And then finally, I think this is the one that they said the quiet part out loud. And I'm going to read this one because I think it's important, but all of them are important. In my experience, the biggest challenge transferring any care is figuring out how closeted or out I can be. Is that one specialist I'm supposed to see going to dead name me? Is the receptionist at the new location going to call me ma'am 100 times before opening my chart? Will the ER doctor tell me that they can't treat my broken arm because they don't know what to treat how to treat a transgender patient? Will that other specialist claim all of my problems are because I'm on hormones and refuse to treat me unless I go off of hormones? Does my gynecologist really truly understand how dysphoria is impacting our interaction? It's these unanswered questions and anxieties that make trans people not seek health care or follow up with specialists or whatever.
Okay, thank you, Scott. So building off of that work, the second phase involved using community-based group model building as a way to elicit mental models or stories from our community members. Can you go back one? There you go. To understand how different groups of LGBTQ plus individuals think about this problem, think about factors related to connections and disconnections from health and mental health care. And this is a widely used technique. It actually has a root in some engineering, and it's a new method to me, which in some ways was a benefit given that this is a method that's really been done in person, and we were moving this to a Zoom format. And so we're actually finding ways to adapt this method for online data collection and sort of innovating around the methodology as well as the stories that we're gathering. So the guiding question that we took for this, based on, you'll notice we don't use the word transitions in phase 2. It was not going to work. And so the guiding question that we used in our model building sessions with community folks and practitioners is this one. What are the factors related to connections and disconnections with health and mental health care throughout your life or the community folks you serve? Next slide, please. So myself and Braveheart Galani and Megan Ray Novak, who are two of my doctoral students at the Mandel School, have been facilitating these group model sessions. And there's a total of 6 groups. We've done them with community experts. So those are LGBT plus identified individuals. 3 separate groups, with 1 group of community experts / providers. So these are people that are both inside or outsiders, 1 group. And then there's 2 groups of healthcare social service providers. Each group has about 5 to 8 individuals in the session. It's a range of ages. So we have a youth group, we had an elders group, and we have a trans-specific group, variety of sexual orientations, gender identities, expressions, and racial and ethnic identities in this sample. Next slide, please. So I'm going to talk a little bit about this method, and then I'm going to talk through some of our in-process findings. We're still iterating around the data collection analysis piece for these models, but I hope that you will see how this process really brings to life the story of individuals and communities and their experiences with healthcare across the life course. So in the first session with each group, we would do 2 activities. And the first activity is a brainstorming where we ask them to identify these factors. And then the second activity is telling stories based on our brainstorm and starting to draw what is called a causal loop diagram, or CLD. Next slide, please. The second session is that we return to the group that we met with and we show them a picture. And it is a causal loop diagram, a picture of factors and relationships that they have identified from their stories that impacted breaks from healthcare, reentry into healthcare, lapses in healthcare, and factors that brought them both in and out of healthcare services. And we bring that model back and tell them, this is what we saw, this is what we heard when we met, and have them react, respond, make corrections, edit, and illuminate other things that were missing the first time. So it really gets to model saturation. Next slide. And then finally, still in process, we will take these individual CLDs. So each group has their own. There will be a youth one, there will be an elders one, there's a community expert advisor one, and there's a health practitioner one. So we'll have these different individual models that we then need to bring into one kind of meta model. And in that process, we then go back to a mixed group of folks and show them this sort of shared picture and get feedback on that. Okay, next slide. So I want to talk through what these sessions actually look like and how they work in this method, and how we've been gathering stories using this. So the first activity we call brainstorming factors. And this picture that you're seeing is a snapshot of what is called a Miro board. It's a sticky post board. It is an online platform that we have access to, and everyone in the Zoom call gets the link and they can open it. And so everyone is on this shared sticky board together. And we have them write factors that related to connection or disconnection to health or mental health care in their life, or in the lives of individuals that they serve, if they're providers. And so these are the kinds of things people start writing. If they don't, we've made adaptations. So for example, some folks that aren't as tech savvy or don't want to write could put it in the chat. They could also speak it out loud. So there was various options for participation, but this first activity, you really see all of these folks' cursors on the same board and writing things in. And so some of the examples here are like compliance, I'm now at ease with my medications. I have a safe space in the doctor's office. I felt like I would be judged, right? People are just writing things. And then what we do is we have them start to tell stories. And so we go around the room and ask somebody to pick one or two stickies that is the most alive for them in that moment, that feels the most sort of powerful, and tell a story about it. And as they're telling their story, we start to cluster those into sort of themed groups. And so here's some examples of the kinds of quotes from stories that people tell at this phase of the brainstorming. Can you click forward, please? So here's someone who said, I'm thinking back to my 30s. I went to Planned Parenthood of East Cleveland, and it's where the lesbians went. We got referred by word of mouth. I felt I was listened to, I was in a safe situation. Later, this participant describes how the East Cleveland site closed, and then she experienced a gap of over 5 years in care. And so this highlights some of those factors, those reasons we're trying to really pinpoint these culturally specific things that bring our community into care, but then also what pulls them out. Next, please. This is a Black trans woman said, as a trans person, you try to go to see the doctor and it's never been heard of. Trans people never even make it to the door. So pretty much the Black market has been our doctor. You know, you're not judged at the Black market, you're not criticized. When you walk into the door, including hospitals, as soon as you walk in the door, you've got staff members snickering, pointing, you know, calling you names. It's always been a barrier before you got to see the actual doctor. Even if you get past the front desk, the nurse who checks your vitals, they're talking crap, bringing in their friends to come look at you. It's like you're on display. And then you finally get to see the doctor and they don't even know how to treat you, what to say to you, how to even acknowledge you. So it's like, why am I even here? I'd rather just stay at home and die. Another individual talking about a long lapse in care and avoiding seeking treatment because of a variety of pathologizing experiences that she had with physicians and other mental health providers, said, "What has gotten me back to being more consistently connected is actually being able to access a doctor at the center through Pride Clinic, and also being able to get lab work done there too. There is a certain relief that arises from being able to see a provider that is non-judgmental, actually listens to you, and also being able to be in a safe space like the center." And this person's talking about the Metro Pride Clinic that's actually housed inside of the LGBT Center of Greater Cleveland. Next slide. Okay, so the next thing that happens, and I know this slide looks crazy, but I'm trying to show you all what the process looks like, right? So what we then do in the group is we take those stories, and people keep telling their stories, and as they're telling them, we have a program called Stella, which is where we make these causal loop diagrams. And as each individual talks, we identify constructs and factors and relationships between them, okay? And so this, what you're seeing right now, is the first round that happens in the first session. You can see how complex it is. And that is something that we are trying to understand, is the complexity, but then also how to synthesize it into into these variables or factors that are sort of consistent across group stories. And what we then do as a team is that we have the Zoom recording now, which is one of the innovations of having this actually audio recorded, is that we go back and we listen again, we watch again, and we draw our own pictures of what we're hearing. And then the team basically does something very similar to a consensus coding process for folks that do qualitative work. And we compare what we've drawn, and we put it together, and we check it back against the transcripts, both the audio and visual transcripts from that session, until we get something that we're going to take back to the community stakeholders. And in the second session, what we would then do is take something that looks like this and talk everyone through it and show them the factors that they talked about in the relationships, and ask them for clarification, and ask them to tell us where are places that we got it wrong, for example. Next slide. So this is another example, a more kind of cleaned up looking example then of a causal loop diagram from meeting with community elders. And we brought this back to our community elders, and we talked it through, and we said, look, we have supports at the top. People identified specific kinds of supports and relationship between those. People also identified a lot of pathologizing. We identified self-medication and how that relates to shame and loathing and sort of internalization of this pathologizing, and the stigma, and how that related to avoiding going to see the doctor until a chronic condition happens, and then it's like we're forced to go, we have no choice. And we sort of talk through each of these, and then the elders were not shy about cutting us off right away and telling us where we were wrong, and which was great. They were like, no, that's not what I said, or you got that part wrong, or what about this part? And so in that second session with them, if you go to the next slide, you'll see this beautiful thing that we tried to create turned into this, right? So now they're adding in more complexity, and they're adding in additional factors. And the stories are building off of one another as well. So each of these blue parts is a factor or a variable that's being described, is not just belonging to one person, right? It's a group consensus process. And there may be some different experiences, of course, within the group, but there's a lot of commonalities as well. And something for sure within the elders that was a strong theme is how it was delay in the earlier years. Delay. I'm not going to go to a doctor, or I'm not going to come out to anyone inside of that, because the pathologizing was, this is our Stonewall generation, right? I mean, these are folks who were out when the American Psychological Association still had us in the DSM as a pathology. And they talked specifically about that. Actually, that is a factor that they actually named. And people were really clear that it was, in earlier life, we were delaying, and folks were not engaging with healthcare until, as one person said, all hell broke loose and I didn't have a choice. And that happened in sort of the midlife. And the types of factors then that they talk about that were connecting them as well. They also talked about, because I wasn't going to the doctor on my own, and there's this internalization and the pathologizing, there was a lot of self-medication. And they talked a lot about how self-medication also kept them from then going to the doctor, because folks said, I knew I wasn't taking care of myself and I was doing things I was ashamed of, and I didn't want the doctor to judge me. So there's a very complex dynamic there around the internalization, self-medication, and then the role of 12-step programs for this generation in particular was profound. Pretty much everyone in our session described in some way the role that 12-step played in connecting them back with some kind of community support, some kind of stabilization, and then building relationships inside of, for example, the gay AA that brought them back into seeing a doctor. The other thing that came up across all of our conversations was the importance of these specifically affirming healthcare locations. So Metro Pride, the Pride Clinic, McCafferty, certain doctors were named across groups. Cleveland Clinic as well came up because they also have a specialized kind of affirmative care for sexual and gender minorities. But that is important for us as we think forward to the transitional care model, or whatever we're going to call it, and where's the best place also sort of co-locate services and mobilize people. Where do people want to go? Okay, next slide. So we are still, in terms of the causal loop diagram process, we are still iterating around the models and refining them. That's where we are. And something that has been really powerful as we're narrating our own stories in these groups, we're connecting to a collective experience. I have one quote here, but there are many, many others that participants shared that I'm kind of shocked and somewhat at ease that other people have had issues other than me. And that's actually kind of comforting. I actually kind of thought it was just me. And that sentiment really echoed throughout our different model sessions that we held with community members in particular. And it was interesting to us as well as the researchers, because we're hearing these stories and we're also, of course, relating our own experiences and recognizing that this shared collective experience is in some ways hasn't changed from generation to generation. And I think that we had a conception that things are better. And I think, in some ways things are better. It's true that we now have places like the Pride Clinic, but not everyone is connected to a Pride Clinic, and not everyone's connected to those kinds of spaces. And for those who are, it's been a massive safety net. It's, we have folks saying, I'm compliant for the first time in 50 years, right? I'm actually taking my medications for the first time. And I'm compliant with them because I'm accessing care in this affirmative Pride Clinic. But that's the minority of us. And to hear the stories echoed across generation is really powerful. And certainly in this time, when we have current legislative attacks specifically on transgender health and healthcare rights and access, this is very timely, and it's critical, and it's life or death in some cases. It's not an exaggerate. It is not an exaggeration to say that these are issues of life and death. So what we are currently then working on again is this sort of building this systemized consolidation and building of this sort of grounded theory based on these different causal models that can help us elucidate factors, processes, antecedents, relationships that contribute specifically to things like lapse in care. Things that came up in our discussion a lot across different groups were the avoidance. Why do I avoid? When do I avoid and delay? The relationship of trauma to that, of medical trauma. A lot of stories of being traumatized inside of medical and healthcare provider settings. So there's interpersonal, there's intrapersonal, and there's structural systemic. But what the causal loop diagrams show is the complexity of interrelationships of things that are simultaneously acting to propel people towards care or tear them away. And it's that sort of simultaneous enactment of multiple kinds of factors that we're really interested in capturing, in tailoring and adjusting, a healthcare handoff model for sexual and gender minorities that is attuned to our specific needs and our histories and our strengths. So that's me. Next, back to you, Scott.
Yeah, so a couple of the challenges that we identified is the fact that, I mean, if it wasn't apparent, pandemics have real effects on real people, period. And those people include scientists and researchers and providers and patients and individuals. And I think that one of the things that the pandemic may have led to is an joyous ability to share real experiences when we were able to ask those questions. So I want to say that this is a challenge, but it also may have been a benefit too. Just like I stated at the beginning, I, again, don't want another one, but I do think that it's important. The pandemic also caused a limited ability to reach those people that don't have internet services or unlimited phone data or usage or safe spaces to be able to have those conversations in. And I think that if we could find a way to give everybody free internet in a safe space, that it would change some of the ability to have those types of dialogues. Might even change the way to access care. But also pandemic protocols for IRBs and changes and expectations, and also, I mean, just changes in the pandemic itself made for some interesting adaptations, but I think that we've made it. And a challenge that I think is also another opportunity is that this data is rich. And I think both Dana and I underestimated how rich this was going to be. And I think also, I mean, I personally have had a lot of emotional responses to some of the things that I've read and seen, and I don't think that I was, and maybe it was the pandemic, who knows? I don't want to blame everything on it. That's a little silly at this point in time. But I'm an emotional human being, so it's allowed. And then the opportunities, I think the first thing is that we are developing a transdisciplinary science team that I think is diverse and adaptive and multi-skilled, and I think it's very exciting. And this opportunity actually solidified something that Dana and I talked about for a while, and this really made it possible. And we've identified opportunities for collaborating beyond the Rainbow Connection pilot itself. We had a publication in the Journal of Homosexuality's COVID, I'm about to say COVID episode. What do you call it? Issue, COVID issue. And it's the most cited out of that group already, and has been the most retweeted and everything else. So that's sort of exciting. But I think the more important part here is that we've strengthened community relationships and really are starting to embed those relationships as a part of the working team moving forward. And that's an important part of community engaged and responsive work. Much like Dana started out with, it's not transactional. It can't be transactional. I think that this has to be something that it's truly it's built in. It's not just a moniker that you add to get funding. And then finally, I think that there's an opportunity for us to address the psychosocial and health needs of SGM communities across the lifespan in Northeast Ohio and beyond. And I think that this work says that has to be done, and truly does create a really strong foundation for us to be able to ask for other opportunities. And then our next steps is to continue processing and merging the data from phase 1 and phase 2. We want to have some community shareback sessions, and some of our participants have asked that they, if possible, be in person and some direct engagement with them. And I think that Dana and I are working to try and figure out ways to do that. Also, there's lots of publications, specifically methods and obviously the results themselves. There's some ancillary themes that are going to come out of this, and I think one of those is the over medicalization or over pathologicalizing of sex and gender minority identities. And we also have a systematic review underway so that when we apply for funding, that we can say that we know these things to be true and not just that somebody else said it. And obviously we're going to be seeking other funding. Again, we want to thank those people that made this possible. And yes, we know that the LGBT Center is on there twice, but they deserve it. It's been an amazing relationship. And again, thank you so much to CTSC and the CNC core. And I guess now we're ready for questions.
As a reminder, for questions, you can type them into the Q&A feature, or you can use the raise hand feature to request that your microphone be unmuted.